Hi, I'm Lakshmi Yatham. I'm the chair of ACUMEN, a WFSBP e-learning program on cognition. In today's module, we're going to talk about cognitive remediation and psychosocial rehabilitation in schizophrenia. There are three things that we're going to try and cover in this module. The first thing is we will look at what's the evidence for efficacy of cognitive remediation in treating cognitive impairment in people with schizophrenia. We'll also look at some of the methods involved in cognitive remediation. And finally, we will look at understanding some of the patient's goals and how one can tailor some of the cognitive remediation and psychosocial rehabilitation strategies to achieve goals for people with schizophrenia. To talk to us about all these issues, we have Dr. Susan McGurk, who is a professor at Boston University. Susan, it's so nice to have you in this program.
Thank you. It's nice to be here.
So we know that people with schizophrenia have cognitive impairment. The question is, does everyone with schizophrenia have cognitive problems, or is it only some people?
Well, it's cognitive deficits are really part and parcel of the illness, and many people do have them. One thing to keep in mind is we determine that someone has cognitive deficits by measuring them as compared to a healthy population. So some people may measure as being in an average range, but that doesn't take into account what they may have lost perhaps during the prodrome or earlier in their cognition. So the point being that even people who are testing as average and not having notable deficits may benefit from cognitive interventions.
So it's really relative to their premorbid cognitive functioning, how much change has occurred because of the illness itself.
Absolutely. Yeah, so they may be in an average range, but they may really feel that loss.
Okay. So what's the sort of magnitude of impairment that we see in people with schizophrenia?
Well, I think actually Phil Harvey did a wonderful job at addressing this particular issue in his interview with you earlier. The magnitude varies. There are areas that are spared, word recognition, etc. There are areas that are one standard deviation below normal, such as verbal memory, aspects of learning, and the worst hit areas tend to be information processing speed and executive functions. And executive functions includes very important skills such as planning ahead, recognizing problems, and solving them. Mm-hmm. These areas tend to be the most impaired across studies.
So Susan, one of the things that comes up from clinicians is, yes, we know people with schizophrenia have cognitive problems, but how does that matter, right? Does it affect functioning, for example?
Yes, very much so. Cognitive difficulties affect people's ability to connect with services. They interfere with the ability to manage their illness. And this is a goal for treatment teams and psychiatry to help people manage their own medications and their symptoms of their illness, but cognitive difficulties get in the way of successfully doing that.
Okay, so it sounds like you're saying not only does it affect patients' functioning, but it might even affect the ability of treating clinicians to help manage patients' issues.
Absolutely. And some clinicians are very good at realizing that there are cognitive difficulties that are barriers to fully engaging and benefiting from the treatment. Other clinicians may misinterpret cognitive difficulties as a lack of motivation to receive the treatment or some other decision on the part of the patient. And so they may not do something to help remove those barriers. Another area where cognitive difficulties interfere, and this is a more recent finding, is in the ability to benefit from psychosocial rehabilitation. So people who have greater cognitive problems get less out of even evidence-based psychosocial interventions, such as social skills training and supported employment.
That's interesting. So I guess then the question is, what strategies are available for clinicians to manage cognitive problems in people with schizophrenia?
Well, that That's a big question, and it's a really important one. In going back a bit, Alice Medaglia was one of the first cognitive researchers to develop a handbook to educate families. So families can be a good source of identifying these problems and helping the person manage them at home. And she wrote with the Office of Mental Health in New York a book for families, educating them about cognitive symptoms in people with serious mental illnesses. Dawn Veligan developed the cognitive adaptation therapy, which also has a family component, but this intervention bypasses cognitive problems and goes into the home and rearranges things about the person's activities of daily living to help them remember things they need to remember, like taking medication. So, for example, a behavioral strategy is to put a rubber band around the person's toothbrush and their medications to prompt them. So these strategies don't engage the person's cognitive problems per se, but rather help the person manage them more effectively.
So some of those strategies sound like what we call functional remediation in the bipolar world. Mm-hmm. Would that be the sort of fair statement, do you think, or what do you think?
Well, functional remediation is a specific intervention. I know it's been applied and tested in people with bipolar disorder. Dr. Vieta has been involved in its development and testing, and it's very interesting because it combines aspect of cognitive remediation, which we haven't talked about at great length yet, but I'm getting there. Which includes in functional remediation intervention, it includes compensatory strategies, psychoeducation, and some paper and pencil practice of cognition. And that combination may be very effective for people with bipolar disorder in both managing their own cognitive problems and achieving what they'd like to achieve in the community.
So you sort of threw in cognitive remediation there, and that was one of the things I was going to ask you. So can you tell us what cognitive remediation is?
Oh, absolutely. So it's a set of interventions that seeks to improve cognition using behavioral principles, primarily striving to improve learning, but really many programs strive to improve a range of cognitive functions with the ultimate goal of improving functioning. So because of the relationship, as we mentioned in the beginning of our discussion, between cognitive impairment and community dysfunction, the idea is that if we can target and improve these cognitive problems, people will be better off in the community.
So what about psychosocial rehabilitation? Because that's the other thing that seems to come up in the schizophrenia literature.
Yes, and it should, because it's really the first set of interventions that have truly helped people improve their functioning in the community and reach their recovery goals. So psychosocial rehabilitation, with its well-developed protocols that are manualized, standardized, have fidelity scales, and substantial evidence that support them, these really should be our first-line treatments in conjunction with medications. So the issue is that whereas cognitive remediation is really addressing a symptom, a cognitive symptom of the disorder, medications address symptoms of the disorder. So some people do not benefit fully from psychosocial rehabilitations, as I said, because cognitive impairments are barriers to learning what they're being taught in, say, social skills training, and then being able to use those skills in the community. That requires executive function, meaning the ability to transfer what you've learned to a different situation. People have enormous difficulties with that. So the idea has become to develop these cognitive programs and integrate them with psychosocial rehabilitation.
So in terms of the goals then, cognitive remediation versus psychosocial rehabilitation, what would you say are the main differences in terms of the primary goals for each of those strategies?
It's a very interesting question. So the goals are the same. The goals of psychosocial rehabilitation are, a set of interventions, I mentioned too, social skills, supported employment. The goal are to help people achieve success in those domains. develop a social network, get and keep a job. Cognitive remediation, it's really two goals. The first goal is to have an effective cognitive program that can improve cognition in service of a community goal. So improving cognitive functioning is only the first step. How that improved cognitive functioning is best used, and this is from the literature in our meta-analyses, is best served by concomitant psychosocial rehabilitation.
If you just use, let's say, cognitive remediation strategy, which sounds like will improve cognitive functioning, could that in itself lead to improvement in functioning, or are you saying it's actually better to combine cognitive remediation with psychosocial rehabilitation, which probably targets more of the functioning? Is that?
That's right.
Okay.
Yeah. So that's the rub with the literature, is that cognitive remediation was initially borrowed from its use in traumatic brain injury to people with schizophrenia who have known cognitive challenges, and to help people improve those skills for the sole purpose of being better off in the community and lessen the disability that we see in independent living skills, activities of daily living, the ability to go to school, be a worker, and other aspects of role functioning to try to lessen that disability. But what we have found instead in two meta-analyses, the first one was published in 2007, and then we updated that in 2011. What we found is that psychosocial rehabilitation is a potent moderator of the effect of cognitive remediation on functioning, meaning that cognitive remediation alone can improve cognition. Good programs, you'll get a consistent half a standard deviation improvement on a cognitive composite score. But that brings us precious little in terms of budging functional issues. And these programs are often called standalone, meaning people come in, they do the cognitive practice, they leave. The expectation is they're better off cognitively, they're going to go back to school or go to work, and that's not what happens. In fact, in programs that combine these cognitive methods, which I'm sure we'll describe soon, with evidence-based psychosocial rehabilitation, that's where you see the real effects of the cognitive gains. So somehow these psychosocial rehabilitation treatment programs are fostering the use of these sharpened up cognitive skills from the training, such as learning, improved learning, and profiting from that.
So that's quite interesting, because you can move the cognition, but it sounds like you can't change the functioning with the cognitive remediation alone without psychosocial rehabilitation.
So far, that's what the corpus of the data show.
Okay. Now, what about the psychosocial rehabilitation itself? So, are there studies that looked at the efficacy of psychosocial rehabilitation, both on functioning and also shift in cognition?
So, thank you, because that's a very timely question, particularly in first episode treatment. So, for example, you're probably familiar with the RAISE study. It's an early treatment program using Navigate, which is a compilation of interventions getting at community functioning. What was found in participants in Navigate as part of this RAISE study is they were better off after several years in their cognitive functioning as well as psychosocial functioning as compared to the usual care group. So there is, and that did not include cognitive remediation, so there is something about engaging these young folks early in their illness in a well-developed psychosocial rehabilitation program called Navigate, and it paid off cognitively as well as in their functioning. So that's an example where you can see psychosocial rehab is improving cognition.
That's very interesting. So obviously we'll have to look at, I guess, in the future, whether, because you were saying that there are some studies that combine both, and those studies seem to show improvement in both cognitive functioning and also the day-to-day functioning of patients as well. So I guess the question is, combining those, does that give you a better bang for the buck, so to speak, in terms of magnitude of change, both in cognition and functioning versus, let's just say, psychosocial rehabilitation alone?
There's a lot to say about that. So support employment, for example, individual placement and support developed by Drake and Becker at Dartmouth. There's over 20 randomized controlled trials nationally and internationally, and the effect size hovers around 0.75. So that's hard to beat. However, there are people who don't benefit from supported employment. A subgroup of people who either don't work or lose the job in getting fired or quitting in an unsatisfactory manner, such that that intervention is not helping them. So what we've done, our group developed the Thinking Skills for Work program and tested it. It includes computerized practice, and we can go into the methods further momentarily, and self-management strategies together, and applied them to people who have failed to benefit from evidence-based supported employment, and they benefited significantly. So that's one aspect of a really good use of these cognitive methods, where the cognitive improvements that occur in cognitive remediation are not squandered. Rather, they're delivered in the context of this support employment program, which capitalized on those.
So we talked about the efficacy of these interventions, but let's now move on to talk about more practical aspects. So can you tell us, what are some of the main components of the cognitive remediation?
So we just, this is a very interesting story. So cognitive remediation really began, it depends. So you had one school who developed these beautiful integrative cognitive programs, Hans Brenner with IPT, Gerard Hogarty and Sean Eek with cognitive enhancement therapy, Morris Bell, neurocognitive enhancement therapy, where there was a combination of some aspect of a cognitive treatment and psychosocial rehab. And so that's really the model that we follow in our research. But then there's also been experimentation of just looking at cognitive training alone, meaning computerized cognitive software that people do either in a clinic or an agency or in their home. It can be accessed through the web. And this has yielded disparate results. So for the most part, some people profit from that kind of practice, but typically in schizophrenia, they don't. So computerized cognitive training as the sole piece of a cognitive program, it doesn't work in schizophrenia. And I think that's been the source of some confusion about how cognitive remediation does work, or if it works. It works differently in schizophrenia because the needs for it are so broad. So what we have discovered in our own research and in others is the need for a trained facilitator while people are taking these computerized exercises to help them get the most out of it. So for some people, having them do it alone in a room or sending them home to do it, it's just not going to happen. They're practicing poor cognitive approaches over and over and probably getting very good at something that's not working for them. So clearly the trends in the literature show without a doubt that people with schizophrenia can benefit from cognitive remediation if you have the building block of the cognitive exercise combined with a good trained facilitator.
The word cognitive remediation doesn't necessarily mean the same thing for everyone. It sounds like there are different strategies there are different ingredients that are part of this cognitive remediation broader category. And you're saying that if we just use the computer tasks as a part of the cognitive remediation, that's not that effective, but you got to add in a few other ingredients, such as having a trained facilitator.
Yes, so programs have become more bundled and include more these bells and whistles, and we've been able to evaluate the value added from those. So In a recent review I did with Phil Harvey, that got and other colleagues, including Till Wykes, that's been recently published in Biological Psychiatry, we made a distinction between computerized cognitive training, which is practicing on the computer alone, at an agency without help, or at home. And we're not even considering that cognitive remediation. That may work for healthy elderly or other populations. It's not effective in schizophrenia. What needs to be added onto the bundle is a trained facilitator, and then to direct those cognitive gains, that cognitive capital, to something the person has an interest in improving, like social skills. They want more friends. They want to get a job. They want to go back to school. Then that bundle of the computer training with the trained facilitator needs to be paired with the psychosocial intervention that's geared toward that person's functional goals.
So we talked about cognitive remediation and psychosocial rehabilitation. I guess the question is, would you offer those strategies to every patient with schizophrenia that has cognitive deficits, or would you somehow pick and choose in terms of what strategy would you use for what kind of patient?
In considering would we offer this to everyone, I would say no. I would first suggest that the treatment team find out what the person wants to accomplish, what their recovery goals are. If they don't know them, what the goals are of their patient, they might ask them and help explore that with them. And once they discover what that goal is, to connect them with the appropriate psychosocial rehabilitation program to help them get there. Now, if they've had a go at that already and have failed for some reason, that would be, in my opinion, a good example of when you'd want to add cognitive remediation for that person's treatment plan. And that may help them get more out of the psychosocial rehabilitation program the second time.
Okay, so it sounds like you're saying that understand the goals, right?
Mm-hmm.
Hopefully patient has some goals, and treating clinician also has some goals. And so you try and match the treatment strategy that has the best ability to help patient or the clinician achieve those goals, more or less.
Absolutely. And let me say one other thing about that. Motivation, people think, is an issue in people with schizophrenia. So if you're offering them this really nice treatment that's combining cognitive elements and psychosocial rehabilitation, that person is going to be far more motivated to work hard in the cognitive intervention because they're desirous of the goal that the psychosocial rehabilitation is helping move them for. And so when you connect the two, the cognitive practice with their community goal, people become much more enthusiastic about trying hard in the cognitive treatment program. So, and that is in contrast where cognitive treatment is offered alone, where people, as I said, are practicing on a computer without help, without a trained facilitator. People quit. There's large amounts of attrition. Even when studies pay them to take that treatment, there is significant attrition. And I think that speaks to making the cognitive practice meaningful through having it geared towards a specific goal and paired with another psychosocial rehab program to help them get there.
So we talked about how we tailor these strategies to patients' goals and needs in people that have an established diagnosis of schizophrenia. I guess my question is, what about people that are at high risk for psychosis, right? They haven't developed a full-blown psychotic episode or have not been diagnosed with schizophrenia as yet, but they're at high risk. Could these strategies be useful in such populations?
Well, in those populations, the first issue that is noticed either by the family or the school or friends is a drop in the ability to function in the community. And so that should really be the first order of business, is to give them that help around staying in school or going back to school or work. if that is not successful, then you may want to add on to that with a cognitive treatment program. The reason why you wouldn't want to start with a cognitive treatment program is we don't know what role cognition had in the person's failure in that domain. We do know that they may be having some struggles in the community. So you want to start with that intervention that matches the behavioral need, for example, failing out of school or getting fired, and then go from there and see if some additional help is needed.
Okay. So in terms of strategies, we talked about cognitive remediation, we talked about psychosocial rehabilitation. Are there any other strategies that clinicians should be thinking about in helping people with schizophrenia in addressing either cognitive deficits or functional deficits?
There are, and I mentioned this earlier, a range of integrated cognitive programs that address more complex types of goals. So I mentioned cognitive enhancement therapy that was initially developed by Gerard Hogarty, and Sean Eek has published an incredible amount and in first episode on this intervention. So people early in their illness may benefit, in fact he has shown that they have, from this combined intervention that is using cognitive practice to improve attention, improve learning, and then slowly move them into groups where they're learning social skills and developing a social network. So that seems very prominent, a prominent intervention and quite important. And there are other combined interventions. So for example, illness management recovery. It's an evidence-based practice that teaches people how to manage their own illness, know their signs of relapse, understand their medication, understand the relationship between stress and symptom worsening, and to really give them the tools they need to manage their own illness. So some people don't profit from that as much, and oftentimes it's people who have greater cognitive impairments. So we did a study where we combined people who were receiving vocational rehabilitation, illness management recovery geared towards their work, and we added on thinking skills, which involves computerized cognitive practice combined with individualized self-management strategies. And that package, compared to vocational rehabilitation alone, help people get the job they want, decrease hospitalization, decrease symptoms, and help people be able to espouse and follow through on a goal.
Okay. So we've covered a lot of ground in this module, Susan. For clinicians, what would you say are key take-home messages?
Well, first it would be to know their patient, to try to understand either through a cognitive evaluation or some other method to help them understand what the distribution of the person's cognitive strengths and weaknesses are. And that can be very practical. So they can discover that by noticing that the person's having difficulty paying attention to them, or they're having difficulty remembering what they want them to remember about managing their illness, or they're not showing up for their appointments, so they may have some trouble with planning. And then to give the person some strategies to help them connect with their treatment. That seems to be a very important use of these strategies. And one set of strategies that clinicians can use and are very helpful are called compensatory strategies. So these don't involve the restorative task practice of the computer practice, although that definitely has its role in schizophrenia. This is part of cognitive remediation, but involves teaching people how to use technology, set alarms, no missed reminders in their daily life, creating a memory spot where you put your keys or your wallet every day so you don't have to look for it, making checklists. There are two such interventions that I'm aware of using these strategies that I think could be easily taken up by clinicians, and that's compensatory cognitive training by Twomley and colleagues, and our self-management strategy component of thinking skills for work. And in that component, we teach people how to develop a routine if they don't have one for their nighttime routine, their morning routine, their job search routine, to get that in place to facilitate their engagement in services. So that sort of bypasses the computer cognitive training and gets right to functioning. So those I think would be useful tools for clinicians to learn. And by the way, we are teaching them to employment specialists who use them with clients they're working with in the community to help them manage their cognitive problems on the job, to diminish their interference from their ability to do their job.
Thank you so much, Susan, for taking the time to participate in this program.
Thank you so much for inviting me.